definition is the types of opiate receptors, tolerance, and dependence. Definition: opiate receptors are specialized protein located on the surface of cells, primarily within the central and peripheral nervous system, that binds to endogenous opioid peptides and exogenous opiate drugs. These receptors belong to the G protein-coupled receptors (GPCR) superfamily, characterized by their 7 transmembrane domain structure. The primary role is to mediate the effects of opioids, which includes analgesia, sedation, euphoria, and respiratory depression. Opiate receptors are critical in modulating pain, perception, reward pathway, and various physiological processes such as gastrointestinal motility and immune response. Opiate receptors plays mal, multifac- multifac- multifaceted roles in both physiological and pathological states. Their function can be broadly categorized into pain modulation, emotional regulation, and homeostatic control. In pain modulation, opiate receptors inhibit the transmission and nocive signals in the spinal cord and brain, providing anesthesia. This is particularly evident in the mu opioid receptors, which is the primary target for the most clinically used in opioids. We have the mechanism of action, which is mu opioid receptors. Mu opioid receptors are the most extensively studied opioid receptors due to the primary role in mediating the analgesic and rewarding effects of opioids. These receptors are widely distributed in the brain, spinal cord, and peripheral tissue, particularly in areas involved in pain modulation, such as para-aqueductal gray and dura horn of the spinal cord. MOR activated leads to targets for clinically used opioids like morphine, fentanyl, and oxycodone. The receptor signaling primarily occurs through G protein-coupled mechanisms inhibiting analytate silase and modulating potassium and calcium channel to reduce neural excitability. Subtypes of MOR, such as MOR-1 and its splice variant, contributed to the diverse pharmacological response, influencing both therapeutic efficacy and side effects. We have copper opioid receptors. Copper opioid receptors are activated by endogenous ligands like dynorphins and are involved in pain modulation, stress responses, and mood regulation. KOR are found in the brain, particularly in the hypothalamus and cortex, and as well in the spinal cord. KOR signaling also involve G protein-coupled pathway, but their downstream effects include modulation and stress-related pathway, such as hypothalamic pituitary adrenal axis, which contributes to their role in stresses and anxiety. Recent research explored KOR antagonists for their potential in treating pain and addiction without rewarding effects associated with KOR. We have delta opioid receptors. They are primarily activated by enkephalins and are experienced in the brain, spinal cord, and peripheral tissue, with high concentration in the olfactory bulb and cortex. DOR plays a significant role in analgesia, emotional regulation, and neuroprotection. The activation processes analgesia with a lower risk of respiratory depression compared to the MOR, but their clinical use is limited due to the potential convulsant effect at high doses. DOR signaling modulates pain pathway and has been implicated in mood disorder with agonists showing antidepressants like effect of preclinical models. The development of selective DOR against is an active of area research for management and psychiatric disorder. We have comparative analysis of receptors function. The four types of opiate receptor MOR, KOR, DOR, and NOP share structural similarities as a G protein coupled receptor, but differ significantly in their ligand specificity, distribution, and physiological effects. MOR are primarily mediators of analgesias and reward, making them central to both therapeutic and addictive properties of opioids. KOR, while effective in pain relief, are associated with dysphoria, limiting their clinical utility by offering potential in addiction treatment. DOR contributes to analgesia and mood regulation with fewer respiratory side effects, whereas NOP receptors have a dual role in pain and stress modulation. We move to tolerance. Opioid tolerance is defined as a reduced response to an opioid drugs following repeated administration, requiring higher doses to achieve the same therapeutic or psychological effects. These phenomena primarily affect analgesia but can also extend to side effects such as respiratory depression. Tolerance developed due to adaptive changes in the opioid system, particularly involve mu opioid receptors, which are primarily targets of most clinically used opioids. The mechanism of tolerance are complex, involving receptors, desensitization, internalization, and attraction in downstream signaling pathway, ultimately diminishing the drug's efficacy. Factors influencing tolerance development. We have doses and frequency of administration are critical, with higher dose and more frequent uses accelerating tolerance. The types of opioids also matters. Drugs with high intrinsic efficacy such as fentanyl. Clinical implementation of tolerance. Tolerance poses significant challenges in clinical settings, particularly in pain and management. Patients with chronic pain often requires escalating opioid doses, increasing the risk of side effects like respiratory depression and dependence. Tolerance of analgesia typically develop faster than to side effects, complicating doses adjustments and reducing the therapeutic windows. Opioid dependence is characterized by a compulsive need to use opioids with harmful consequences, often accompanied by psychological and physiological adaptation that results in withdrawal symptoms upon cessation. American Psychiatric Association. Dependence is an hallmark of opioid use disorder as defined by Diagnostic and Statistical Manual of Mental Disorder and include criteria such as tolerance, withdrawal, and unsuccessful attempt to reduce use. Key characteristics include cravings, loss of control over opioid use, and continue to use despite negative social, occupational, or health outcomes. The neurobiological basis of opioid dependence involves adaptation in the brain's reward, stress, and pain system, primarily mediated by mu opioids. Risk factors for developing dependence. Multiple factors that increase the risk of developing opioid dependence. Biological factors include genetic predisposition such as polymorphism in the OPRMI gene encoding (MOR), which can enhance opioid rewards and accelerate dependence. Mug and blending. We have environmental factors too, such as exposure of trauma, chronic stress, and socio-economic disadvantages, heightening vulnerab- vuln- vulnerability by altering stress and reward. Psychiatric comorbidities include depression, anxiety, and post-traumatic stress disorder are strongly associated with dependence. Also involve as individual may use opioid to self-medicated. How tolerance contributes to dependence. Opioid tolerance, characterized by diminished response to opioids after the repeated use, is a key driver to dependence. As tolerance develops, individuals require higher doses to achieve the same analgesic or euphoric effects, increasing opioid exposure and promoting neuroadaptations that underpin dependence. This escalation enhances activation of the brain system, particularly in the mesolimbic pathway, reinforcing drug seeking before the first hearing psychological dependence. Tolerance and dependence share overlapping neurobiological mechanisms, primarily involving mu opioids and downstream signaling pathway. Both processes are driven by receptors desensitization and intercitation, mediated by G-protein coupled receptor kinases, which reduce MOR responsiveness and availability. Chronic opioid exposure also upregulates com- compensatory systems such as adenosine, such as salicylic adenosine, and we have challenges in managing tolerance and dependence. The interplay between tolerance and dependence complicates clinical management, particularly in chronic pain and opioid use disorder. Tolerance necessitates higher doses, increasing the risk of dependence and overdose, while dependence per- perpetuates drug use to avoid withdrawal, further enhancing tolerance. The viscous cycle challenges clinical to balance pain relief with the risk of addiction and adverse effects. Differences between opiate tolerance and dependence. Tolerance refers to a reduced pharmacological response to an opioid after repeated administration, requiring higher doses to achieve the same effect, such as analgesia. It is primarily psychological adaptation to the drug presence affecting its efficacy. Dependence, in contrast, is a state characterized by compulsive opioids. Dependence, in contrast, is a state characterized by compulsive opioids use despite harmful consequences, often accompanied by physical and psychological reliance on the drugs. It includes the withdrawal system upon cessation and is a hallmark of opioid use disorder as defined by Diagnostic and Statistical Manual of Mental Disorder. Tolerance. The mechanism: tolerance arises from cellular and molecular adaptation in opioid signaling. Prolonged opioid exposure leads to receptor desensitization where MOR become less responsive due to phosphorylation by G protein-coupled receptor kinases and internalization mediated by B-arrestin, reducing receptor availability. Dependence involve borders neuroadaptation in reward, stress and pain circuits. Chronic opioids use enhances dopamine release in the mesolimbic pathway, reinforcing drug-seeking behavior. Strategies for managing tolerance. We have opioid tolerance, where repeated opioid use reduces drug efficacy, poses significant challenges in clinical settings, particularly for chronic pain management. Severe strategies aim to mediate tolerance while maintaining effective analgesia. Opioid rotation. Approaches to treating dependence. Treating opioid dependence, characterized by compulsive use and withdrawal system, requires a multifaceted approach targeting both physical and psychological components. To my conclusion, the study of opioid receptors, tolerance and dependence provide critical insight into the pharmacological and clinical challenges associated with opioid use. Opioid receptors include MU, um, KOR, DOR, and non-septin receptors mediate the diverse effects of opioids from analgesia to reward distress modulation. Tolerance, characterized by the reduced opioid efficacy and repeated use, arises from receptors desensitization. Clinical strategies such as opioid rotation, adjuvant therapies and medication assisted treatment with drugs like buprenorphine address tolerance and dependence, while receptor-specific therapies, including based MOR against NOP. My next topic. We're done.
Thank you. Please, can we give another round of applause, please? Um, Thank you very much. I like this topic. I have special interest on the topic. It's a very important topic because drug abuse, misuse, addiction, and whatever you call it is on the rise among our youth these days. So it's a very wonderful topic, and I like what she did. But I want to make, this is an academic exercise. I want us to have this mindset that it's an academic exercise. It must not be what perfect. You are all learning. So if you have that mindset, then you'll be disposed to learn, and you'll be eager to know where you did well and where you did not do well. So you can do what? Improve. And that time, I will together. So please, the only thing I can say in this presentation is that please let us try to own our work. Own our work. You have done your research. Make sure you understand everything you want to talk about, starting from how to pronounce them to what they mean. Am I communicating? It's very important. You must not know everything. If there are some words you don't understand or you know how to pronounce, you can ask questions. You can even reach out to me or anybody. Please, what does this mean? How can I pronounce this? So that is the only thing I notice in this work. And it affects the understanding. Are we together? Please note that point. Is that clear? It's an academic exercise, so nobody is coming here to show that he knows. No, we are here to learn. Are we together? So please for those that will say come out to do their presentation, please let us own our work. Very important. Own it. It's your own. It belongs to you. That topic, it belongs to you. You prepare the topic and you fix the time for us to come here. So you should own it and tell us about it. Is that clear? All right. So our audience, please be with us, stay with us. We'll be back in the next few minutes for the next topic. Thank you very much. We love you all.